Now we're going to switch gears a little bit. Our next presenter is going to discuss methamphetamines, which, as everyone knows, is a rapidly escalating problem, ever more challenging. So those of you who attended the May conference will remember we spent a significant amount of time discussing stimulants, with much of the focus on the development of pharmacotherapies. So this talk is going to focus more on non-pharmacologic approaches and the clinical challenges of providing treatment to individuals with methamphetamine disorder. So our speaker is Richard Rawson, PhD. He's a professor emeritus at the UCLA Department of Psychiatry and a research professor at the Vermont Center for Behavior and Health at the University of Vermont. He received a PhD in experimental psychology from the University of Vermont. Dr. Rawson conducted numerous clinical trials on pharmacologic and psychosocial behavioral addiction treatments for the treatment of individuals with cocaine and methamphetamine use disorders. He was a member of the Federal Methamphetamine Advisory Group to Attorney General Janet Reno in the late 90s, and he represented the US at numerous international meetings on methamphetamine. Dr. Rawson has published widely and has conducted numerous workshops, presentations, and training sessions. Welcome, Dr. Rawson.
Good morning. Thank you for the invitation to participate in the meeting. Hopefully I can give you some useful information. As you heard, my duration goes back a ways to Janet Reno, and during the Clinton administration, we were dealing with a severe methamphetamine problem that was primarily in the West and Midwest. It made it into the East Coast to some degree, but it was mainly a Western and a rural problem. One of the take-homes I'm going to be providing today is that our current methamphetamine problem is different. The drug is different. The extent of its spread is different. The source is different, and the consequences are different. So even though we had a previous methamphetamine serious public health problem with methamphetamine in the 90s and the early 2000s, the drug we're seeing now is quite different, and the problems we're experiencing are quite different. I'm going to try to use person-first language here, which is not always easy for me. I started in the addiction world in 1974 at UCLA when we were treating people with heroin dependence. And at that time, calling them addicts was one of the better things we called them. However, now we're trying to use language in which we use person-first, individuals who use cocaine or methamphetamine, rather than the more stigmatizing terms addict or user. But because old habits are difficult to break, I may inadvertently use my older and more stigmatizing terminology, and I apologize. I'm trying to make a language shift. This is the drug we're talking about. Methamphetamine used to be called, or still is called, crystal methamphetamine. In the earlier period of methamphetamine use in the US, we saw some powder methamphetamine used, but now it's virtually all this crystallized form, and the source is virtually all coming in from across the border. The days of the Breaking Bad labs and what we fondly referred to as the Beavis and Butthead labs that were popping up in rural areas throughout the US. There still are some labs, I'm sure you have them in North Carolina, but they're far less and producing far less of the drug than in the earlier era of methamphetamine. The pseudoephedrine and ephedrine were the precursors back in the 90s and early 2000s. And so that was the source of the precursor. The pharmacies were the source of the precursors for making methamphetamine. And you could buy it in cases, bottles of 500 tablets of pseudoephedrine. And that really was the main supply for where methamphetamine came from. Of course, during that era, we had the problem of meth labs. They were blowing up, and killing people, and narcotic squads had to be exposed to all the precursors. So it was kind of a mess in the community where the manufacture was being done. In 2005, Congress passed the Combat Methamphetamine Act, which restricted pseudoephedrine. Those of you who have allergies or hay fever and use pseudoephedrine products now understand you buy them in blister packs. There's limited amounts. You can often only buy 2 packages. In some states, they're put behind the counter. So other states, you have to sign for them. But the widespread availability of pseudoephedrine really was limited by 2005, and it had a major effect. I was going to conferences at that time with a lot of the law enforcement folks, and there was a great deal of sort of slapping each other on the back, saying we've eliminated the methamphetamine problem. And in fact, it did reduce the methamphetamine problem for about 3 years. You'd still get some people manufacturing methamphetamine. That practice they called smurfing, where they would drive around to 10 or 15 pharmacies and buy whatever number of packs of pseudoephedrine they could get, and then they would cook it up at home. But that really was not a way to maintain a large methamphetamine production system. So we really did see a reduction in labs, lab explosions, all the nasty stuff from the manufacturing process, and that was a big plus. However, as we've seen so often, supply reduction strategies can have an effect, but usually they're temporary. And in this case, they lasted about 3 years. And then the cartels, the drug cartels, stepped in and increased their production. The laboratories now that are producing methamphetamine in Mexico don't look anything like the mom and pop labs in the US. They're large factory type operations with full staffs and are they're producing a huge amount of methamphetamine now. And this gives you, though, some indication of the meth lab phenomenon in the United States. In 2003, there were almost 25,000 meth labs seized, and by 2017, it was down to about 3,000. So the combat methamphetamine law did reduce dramatically the meth lab problem. However, it did not reduce the meth availability problem. In fact, the methamphetamine availability is now wide. There's more meth available. It's cheaper, and it's available in more places than it was during the 90s and early 2000s. And it's now manufactured with a different precursor, a drug called P2P, which is produces a far more potent and potentially lethal drug. As you'll see in the statistics I talked about, a lot of the deaths we're seeing today that are associated with cocaine overdose are really being driven by fentanyl. With methamphetamine, it's different. A lot of the deaths we're seeing associated with methamphetamine do not have fentanyl in them and are directly a result of the more lethal form of methamphetamine. But I'll get to that story in a minute. As you can see, 2018, border agencies 10 to 20 times the amount they did a decade ago. And they generally assume they get somewhere in the neighborhood of 5 to 10% of the drug coming across the border. Actually, there was a story 2 days ago about the largest seizure of methamphetamine ever in the United States on the border, 2,300 pounds that were seized, along with a couple hundred pounds of fentanyl that was coming into the country. So the availability of methamphetamine is much more widespread than it was. We're seeing methamphetamine here in New England for the first. I'm in Vermont, by the way. After leaving UCLA, I moved back to my original home at Vermont and set up an animal rescue and was intending to retire. However, this whole stimulant thing has changed my plans slightly. But we do see methamphetamine here in New England. That was not true in the earlier epidemic, but virtually all of it comes from Mexico. So we have more methamphetamine, we have more lethal methamphetamine, and we have methamphetamine with fentanyl in it. And that started in about 2014. The prior presentation talked about the increased availability of fentanyl, and fentanyl now comes in methamphetamine. The meth that's imported and cocaine have fentanyl mixed in. So it's not as though the end user is mixing them together. The drug actually, as it's imported, already has fentanyl in it. So users, some of the overdose deaths we've seen have been users buying their methamphetamine or their cocaine, assuming they're getting methamphetamine and cocaine, but discovering, or after their overdose, learning that the drug included fentanyl. In June of 2020, we had the first report of a drug called isotonitazine, or referred to as ISO, which is another opioid, synthetic opioid, roughly the same potency as fentanyl, that is now being seen in cocaine overdoses in the Midwest. Don't know how widely distributed that is at this point, but the point, I think the important point is that the dealers, the traffickers, the cartels are very sophisticated organizations that are not mom and pop drug dealers. They know how to get the supplies. One of the reasons it's thought that this ISO is showing up is that during the beginning of the pandemic, there was a reduction in fentanyl supply from China. One of the leading supply locations for fentanyl out of China is Wuhan, which was the center of the early pandemic. And for about 2 months, everything was shut down coming out of Wuhan, and the cartels didn't have an adequate fentanyl supply. So they're looking to diversify their supply, their opioid. And so this isotonitazine may provide them with an alternative product. And also they're developing their own ability to manufacture fentanyl. So you're going to see fentanyl or something like it in the drug supply going forward, probably for indefinite period of time. You heard some from the previous speakers on this course of the opioid crisis. I'm just going to quickly go through what are called the 4 waves of the epidemic. This was the prescription opioid deaths across the country from 1999 to 2017. You notice in about 2010, there was a slight leveling off of prescription opioid deaths. And that was probably attributed to the fact that that's exactly when we started to see an escalation in the heroin-related deaths, as heroin replaced prescription opioids to some degree and became the primary source of opioid overdose deaths. However, when we started to see fentanyl show up in 2014, we saw this dramatic escalation of deaths related to fentanyl. Fentanyl became the main killer in the package of drugs that we're seeing with overdose. And what is now referred to as the 4th wave is this stimulant, increase in stimulant-related deaths. As I'll mention, some of these are cocaine and methamphetamine together in roughly equal amounts. I'm talking today about methamphetamine, but I could easily be talking about a very similar set of issues around cocaine. Cocaine has not gone away. Cocaine is increasing. The difference between cocaine and methamphetamine markets are the methamphetamine markets tend to be Western and Midwestern and rural. The cocaine markets tend to be Eastern, urban, and particularly in the African-American community. And one of my other take-home messages is, yes, as we gear up to deal with a new methamphetamine public health issue, we should certainly not forget to provide equal attention to the cocaine public health issues that we may have become a bit adapted to in the inner cities, that, you know, it's there's always going to be cocaine. The rates of death are really increasing, as you can see, and our need to get evidence-based treatment to address the meth problem is no less of a problem than our need to get evidence-based treatment into the inner city clinics where we're seeing high rates of cocaine deaths. This is another way of looking at this. This is on the y-axis is age-adjusted deaths per 100,000. Non-Hispanic whites, we're seeing approximately an equivalent number of deaths from cocaine, the dark bar, or methamphetamine, the light blue bar. In the middle set of bars, among Native Americans, non-Hispanic, American Indian, Alaskan Natives, you see that's the population that has the highest rate of methamphetamine-related deaths. On the reservations and in Native American communities throughout the US, methamphetamine really has made a major public health impact. However, if you look at the second set of bars, among the African American community, cocaine still is by far the biggest killer. And that's one of the issues that I think is getting overlooked as we're now starting to, freak out about the new boogeyman of methamphetamine. I think it's important to make sure we don't overlook the fact that the same kind of public health crisis is occurring but among African American communities with cocaine as we're seeing in other communities with methamphetamine. This is a little bit more on those data. These are cocaine-related deaths, 2003 to 2017. The solid blue line on the left-hand panel is total number of cocaine-related deaths. The two lines under it are deaths that include synthetic opioids or any opioids. The dotted line is any opioid. The dashed line is fentanyl, essentially. So you can see that the cocaine deaths, the spike in cocaine deaths is really being driven by the deaths from opioids. So when you hear that there's a huge increase in cocaine-related deaths, it's this cocaine fentanyl product that's causing the deaths. If you look at ATS's amphetamine-type stimulants, if you look at the methamphetamine numbers, again, you see a big increase in the last 5 years, 7 years. However, the degree to which fentanyl is driving those deaths is much less among amphetamine use than it is among cocaine use. So the methamphetamine itself is producing a significant number of deaths. Now, that has a significance because as we see more methamphetamine around, people who are in ambulances or who are EMTs and are going out to do resuscitate individuals from overdoses now don't know quite what they're looking for. They're geared up to look for opioid overdose. They have Narcan, they have that. But with ATS death, with methamphetamine deaths, Narcan may not be effective. It may be because they may have fentanyl as part of the overdose, but they may also be primarily, their health risk may be primarily from the methamphetamine itself. This is some new data on mortality among people with problematic use of methamphetamine. Methamphetamine users have a 6-fold elevated risk of mortality compared to their non-drug using peers. Men at 2.1 times the risk of mortality compared to women. Most common causes of death: drug poisoning, accidental injury, suicide, and cardiovascular disease. It's important to note, as we've seen these rates of increase of stimulants, both cocaine and methamphetamine, we're seeing a lot more deaths related to medical consequences of these stimulants than we've seen in the past. For those of you who are in the business of treating individuals for opioid use disorder and are buprenorphine prescribers, first I want to say thank you to you. You've saved thousands of lives by getting buprenorphine into the communities, and the increase in buprenorphine prescription has been, I think, one of the most significant public health activities of the last 20 years. And it really has made a huge difference in our ability to increase access to treatment for people with opioid use disorder. However, here's some data on the association between methamphetamine use and retention among people with opioid use disorder treated with buprenorphine. This is from the state of Washington. They here admitted about 800 patients into buprenorphine treatment. About a third of the patients were using methamphetamine at the time they were admitted into buprenorphine treatment. This gives you an idea of how that methamphetamine use, co-use, affected retention in treatment. If you look at the retention curves, the top line is those individuals who were not using methamphetamine at admission, and the lower line is the rate of retention of people who were using methamphetamine. As you can see, there's about a 50% reduction in retention if you're also using methamphetamine. I was impressed to see that about 50% of their patients were retained out to about 800 days, which is pretty, 2.5 years, that's pretty impressive. However, if you look at those who were the meth users, if the individuals who used meth, you see in the first 100 days, there was a real drop off in retention. Now, it's possible some of those early dropouts were not dropouts, but were people being kicked out of treatment because they're using methamphetamine as they were getting buprenorphine. My loudest take-home message for the day is don't do that. Don't kick people out of treatment who are taking methamphetamine or cocaine or cannabis while they're on buprenorphine. They don't get better. In the current environment, they get dead. And so although it's not optimal to have patients in treatment with buprenorphine who are continuing to use stimulants, I would ask people to try any other strategies they can come up with, seeing them more frequently, providing them with more harm reduction information, giving them information on the dangers of stimulants. I can tell you that a lot of I interviewed a bunch of those patients here in Vermont who were on buprenorphine using, here it was mostly cocaine. They don't see it as a problem. And I mean, if your only response is to kick them out of treatment, with the drugs on the street that are available, you're putting them at very high risk for death. And so it's, yeah, it certainly is challenging. No question that it's not an easy patient population to manage, but hopefully you can come up with some other strategy than kicking them out, taking them off buprenorphine for their stimulant use. And so I won't do any more lecturing now. I apologize. Impacts of methamphetamine use. Martin Paulus and his colleague from University of California at San Diego just published a JAMA Psychiatry review of these issues. This is an excellent paper and is very comprehensive about these different issues. First off, Martin does brain imaging. He does a great job of describing the brain imaging data on individuals who use methamphetamine. We first started getting involved in this around the late 90s at UCLA. We had a researcher, Edith London, who came to UCLA, and we developed a big brain imaging program around methamphetamine use. And Nora Volkoff did a lot of her studies during the late 90s. And what we now have is a clear message that methamphetamine damages the brain. It affects the dopamine system and other systems. You get destruction of cells, you get reduction of transporters, you see real dysregulation of the dopamine system that has a persisting effect even after they stop their use. In general, Martin's conclusion is the overall brain state is consistent with degenerative central nervous system diseases. In my lectures to counselors and others, I talk about you really need to start thinking about treating this patient population as people with traumatic brain injury. Their brains are not working correctly. Methamphetamine damages the brain, and that damages their thinking and changes their behavior. Among some of this is very well laid out in Martin's paper, but some of the highlights, cognition is dramatically affected. During the use and soon after in the early recovery period, you get big changes in motor performance, verbal fluency, attention, and all kinds of memory tasks. Even after prolonged abstinence, you see poor learning efficiency and comprehension, visual spatial processing, and slow psychomotor speed. You get what we've seen a lot of is language difficulties. People are not able to properly word find. They can't label things correctly. Their memory is impaired. And this has serious consequences when you're trying to treat people with verbal and behavioral treatments. They don't remember much. Whether they actually get the information and then forget it, or whether it doesn't process, we're not quite sure, but we know that they clearly are not firing on all cylinders. About 2/3 have show cognitive impairment. Impairment is associated with older age, longer duration of use. I missed one here, which is route of administration. Everything regarding methamphetamine use is worse if you inject it than if you don't inject it. So injectors have much more severe cognitive impairment, and those who are regular users. You see among the use patterns of meth users, you see lots of them, the majority will use on a sporadic basis, every weekend, a few days. They're not like individuals who use opioids who have to use every day. So you get a lot of meth users who are sort of sporadic. They'll stop and start, they'll go a couple weeks, then they'll relapse back to use. If they're daily users, however, you're getting, again, it's more like injectors. So the really heavy users and the injectors are different than everybody else. They have a much more severe syndrome, not just in terms of cognition, but in virtually all other measures. And so you have to remember their ability to follow through on cognitive information is been impaired. There is a relationship between methamphetamine and violence. This is a meta-analysis, and this is mediated almost exclusively by them becoming psychotic. Meth users become psychotic, very common. Virtually all of them develop some temporary psychosis at some point. It's a combination of both the active drug effect and sleep deprivation, because they'll often go 2 or 3 days without sleep, and then pretty much they're seeing things and hearing things and are paranoid, and that becomes sort of the world in which they live. And when they're provoked, they can become violent, and that's why protocols for managing people with methamphetamine psychosis in the emergency department, suggest getting them into a quieter place, getting them out of the bright lights and noise of the ED into a quiet room and letting them kind of wind down, which they will do without really much of any medication, as long as they don't, get so violent that they hurt themselves or risk hurting other people. But really, the key to the methamphetamine and violence issue isn't that they're somehow more inherently violent people, but the psychosis tends to create the risk of violence. Martin's paper does a great review, one of the first reviews of this issue, which is that individuals who use methamphetamine, we're now seeing much higher rates of stroke and cardiovascular disorders with this population than we have in the past. The old methamphetamine didn't seem to produce these kinds of problems to the same degree that the new P2P methamphetamine produces. I just did this talk in California for primary care doctors in FQHCs throughout California. Many doctors reporting strokes of young 30 to 40-year-olds related to their methamphetamine use. Lots of high blood pressure, lots of headaches, and other effects. The drug is affecting the brain. Also, the cardiovascular system, pulmonary hypertension, cardiac arrhythmias, cardiomyopathy, and heart attacks that we're seeing with this population. This is a study done, a meta-analysis of reports of articles, and there actually were 77 articles on strokes in young adults who were using methamphetamine. And as you can see, there's a combination of both hemorrhagic strokes and ischemic strokes. You tend to be at more risk for bursting a blood vessel in your brain if you're an injector. If you're smoking the drug, inhaling the drug, you're more likely to have ischemic strokes. And so it's important to realize if you're starting to see increased use of methamphetamine in your area, it's important to realize to be aware of the symptoms, signs and symptoms of stroke, and to be prepared to have patients who are experiencing this as a result of their methamphetamine use. Last year, a great paper, this is a nice short paper that the folks, Schmitz and Adam Gordon and colleagues have done on stimulant use in pregnancy. So if you're treating pregnant women, I would highly recommend this paper. I just wrote a review. I had to write a section for SAMHSA on this, and this was the paper I used. Pretty much gave me my outline for the stuff I had to write. Really well-written paper. We see lots of women, pregnant women, we see lots of women who use methamphetamine. Methamphetamine, when we started seeing it in the 90s, we were really struck by the fact that we were seeing more women than we had with our opioid populations in the past. And that's pretty much been consistent, that with methamphetamine use, we see a large number of women involved. And we know that women with stimulants, when women start to experiment with them, they progress to addiction much more quickly than men. So you'll see the process of them developing severe problems occur much more quickly. And we see there is, in California, for example, the number of pregnant women positive for methamphetamine is about 3 times higher than for opioids. And California has a bad opioid problem, but this is an issue that really has ballooned in the last several years. They do a meta-analysis on both cocaine and methamphetamine. With cocaine use by pregnant women, they find that they get increased risk of preterm delivery, low birth weight, small for gestational age, earlier gestational age at delivery, and reduced birth weight. That's with cocaine. With methamphetamine, a second meta-analysis finds that methamphetamine used during pregnancy is associated with earlier gestational age at delivery, lower birth weight, smaller head circumference. Infants with prenatal exposure to methamphetamine exhibit a more robust withdrawal syndrome, jitteriness, drowsiness, and respiratory depression. Both cocaine and methamphetamine are excreted in breast milk, and if the mother continues to use, breastfeeding is contraindicated. On the effects on the offspring, on the babies, Krista Roth and group from published did a big study called IDEAL, and some of their data where they compared 204 methamphetamine exposed children to 208 unexposed found that at 3 years, heavy prenatal meth use, that is more than 3 days a week, was associated with higher levels of anxiety, depression, and attention problems for the 3-year-olds. At 7.5 years, you saw that methamphetamine exposed kids had poorer cognitive function. We did a study in San Bernardino, California during this period with 5-year-olds, 4 and 5-year-olds, and we found specifically much impaired verbal fluency. That is, their language acquisition was more impaired than the non-exposed kids. So there certainly is some effect of prenatal stimulant use during pregnancy. Nora Volkoff recently published an article on the collision of COVID-19 and the addiction epidemics. I think there's starting to be a much greater literature on this topic. We know that most of the various drugs that people take in the US, whether they smoke them, vape them, or inject them, they produce effects on the pulmonary system, and that if you have pulmonary impairment, your response to COVID is likely to be more severe. There's a bunch of new papers. I need to update this data because I just saw one of your North Carolinian folks. Andre Jones just did a presentation here in Vermont. She had some great data on COVID and the effect on addiction and addiction treatment. So I contacted her and I'm going to adapt her slides. She gave me permission to do that. But the other big issue is, as was mentioned in the earlier presentation, the COVID crisis has definitely resulted in an increase in overdose deaths. Depending on where you look in the country, it's anywhere from a 20% increase to a 40% increase. And that has, the reasons for that, I'm sure lots of reasons. People tend to be more isolated. They tend to be more depressed. They're more under stress. With social isolation, they're not around other people to bring them back with naloxone. So the overdose death issue has really become exacerbated by the COVID-19 epidemic. And we're going to be seeing even more this apparently over the next 6 months to see how this continues on. Clinical challenges. Okay, so if you have been treating individuals for opioid use disorder, and that's been your main focus in terms of addiction treatment in recent years, this is a different problem. People show up for treatment or in the health system with a different array of symptoms. First off, that first one bullet I've talked about already. I never had that bullet in my earlier lectures on methamphetamine back in the early 2000s and the 90s. Overdose deaths were really not discussed around stimulants that much. But now, obviously, it's a major focus. And as with opioids, it really has to be our first priority is to make sure we address reducing death risks among that population. The next two, this limited understanding of stimulant addiction and ambivalence about the need to stop use. I know many of you have seen opioid users or individuals who use opioids who are ambivalent about stopping, and they don't really think they're addicted. However, at some point, because of the withdrawal, because of not wanting to get sick, because of being willing to do anything to avoid withdrawal symptoms, they recognize that they probably should get some help. And buprenorphine and methadone have really provided an excellent way of engaging them into treatment and reducing their withdrawal symptoms and their use. Well, with stimulants, we don't have that. First off, they can stop and start on their own. As I mentioned, you see people using meth and cocaine who use in binges, and then they stop, and then they go back to use for a weekend, and then they stop. And they say to themselves, look, I'm not like the individual using opioids. I don't have to use every day. I can stop, so I'm not addicted. That contributes to this ambivalence that, well, if they're not addicted, do they really need to stop use? Is this really all that much of a problem? In my interviews I did here in Vermont with these patients on buprenorphine who are using cocaine, I interviewed 25 people. 23 of them said they didn't really see any problem with their stimulant use, that their opioid use had been ruining their lives and had put them at risk for dying. And they were tremendously grateful for buprenorphine treatment. But their stimulant use was different. It really was something they did because they were bored on the weekend or just wanted to have a good time. They didn't see it as a problem. The only problem they saw was their prescriber thought it was a problem, and that was an issue. But so first off, and this is true not just with patients on buprenorphine, but stimulant users in general, just have a much lower urgency for getting help. As I mentioned, their brain is affected, impulsivity and poor judgment, cognitive impairment, poor memory. The hallmark of early recovery, the first few months of recovery from stimulant dependence, is anhedonia. Nothing feels good. Life kind of sucks. It's a dopamine depletion syndrome. Your dopamine system isn't working well, so you just don't have the juice to feel good. And so oftentimes what you hear them saying is, if this is how it's going to feel to be sober, I can't live the rest of my life like this. I can't live in this state of mind. And that will often be a justification for them to go back to using. So anhedonia is a big thing. Hypersexuality is a major issue for individuals who use stimulants. This is very different than with individuals who use opioids, where opioids often become the substitute for sex. Here, the drug and sex go very powerfully together. They get very connected, and often in recovery, sexual arousal can trigger craving, craving can trigger sexual arousal. It all gets tangled up together. Violence and psychosis, I mentioned. I also should say, and I don't know how this fell off this slide, paranoia is very common. Paranoia, and I don't mean psychotic paranoia, but sort of sub-psychotic paranoia where they're just suspicious. Even if they're not psychotically paranoid, there's a low-grade paranoia which really affects your ability to engage them in treatment and get them connected to treatment. If you think of the withdrawal with opioid use, individuals who use opioids, if you think sort of the nub of the addiction is this, I want to avoid withdrawal thing that they have. I will steal TVs or I'll do whatever I need to do to get money, to get drugs because I don't want to get sick. That's like the hub of this, the driving of their drug seeking behavior. Not true with individuals who use stimulants. The hub of their issue is this Pavlovian triggering that occurs, where things associated with their use, people, places, things, money, times of day, a whole range of things, emotional states, will often trigger their craving. They don't understand it. They are clueless as to why they feel like they have to use. They just know all of a sudden they had to use. That's part of what covered in treatment. High rates of psychiatric comorbidity and retention is our biggest challenge with this population. These are some of the groups that really need particular attention, those who inject, those who are daily users, as I mentioned. Those two categories often are people who have trouble stopping their use on an outpatient basis. They just don't, their brain is too damaged or temporarily impaired for them to get it together enough to stop on an outpatient basis. And I think many of them would meet the ASAM criteria for needing higher levels of care to get their use stopped. Women, as I mentioned, you see a high proportion of the users, of the individuals are women, and they have obviously trauma issues and abuse, both historic and current, when they show up for treatment. Homeless, chronically mentally ill, individuals with high psychiatric symptoms. In some of the cities in the US, we're seeing the homeless population, we see 60, 70% of the homeless population using methamphetamine. Oftentimes when you interview them, they'll talk about they have to use methamphetamine to stay up at night to keep people from stealing their stuff. And so they'll take meth use to stay up to protect their, the stuff they have that is their life. Men who have sex with men, that's been a group that has been studied extensively in the 90s. This was a huge focus because this is one of the groups that continues to have higher rates of HIV infection, and the sexual behavior that it gets connected to their meth use often is a real driver of high-risk sexual behavior and transmission of HIV. Younger people and individuals in medication treatment for opioid use disorder. Depending on where you are in the US, the rates of patients on buprenorphine who are using methamphetamine in the West and cocaine in the East are quite high. In San Diego, for example, it's over 70% of the buprenorphine patients use methamphetamine. In California, in general, it's around 50%. So we see it in a very high proportion of people on buprenorphine and methadone. Okay, clinical interventions. This one is, I thought, an interesting one, just published on what the emergency room, what the EMTs see when they go out with a meth overdose. These are 2 case studies. 21-year-old unresponsive after ingesting methamphetamine. Temperature was 108. Cooling blankets and bags of ice were applied, but after 46 minutes, the temperature was still 104. The patient was put in a body bag filled with an ice slurry, and the temperature dropped to 97 degrees. The point of this paper is to introduce this idea of this body bag with ice in it as a way of bringing down the high temperature. This is the second case study, 46-year-old using meth, temperature 107.2. By the way, these temperatures 107 and 108 are pretty common among meth overdose cases, and the cause of death can be from these elevated temperatures. So there's a real urgency to get temperature reduced quickly. And in this case, the person was put in this body bag immediately with the ice slurry, and it temperature dropped to 98 within 32 minutes. This is a graph of the temperature drop. The first line, the solid line on the top, is the first case study where they use the standard treatments for reducing high temperature until where the asterisk is, and then they put them in the body bag with ice and it dropped. The second one is where they use the body bag with ice right away. So this is something that probably EMTs are going to need to be adopting as a way of addressing meth overdose cases. Harm reduction, I heard you, the previous speaker, talk about harm reduction in North Carolina. I actually talked with one of your North Carolina colleagues who now works for a federal agency, and he told me about a lot of the very innovative stuff being done in harm reduction for stimulant use in North Carolina. But these are some of the standard things. First, educating them about fentanyl is important. Syringe exchange, obviously, people who are injecting methamphetamine need to use clean syringes. Naloxone being given to stimulant users because there's so much fentanyl in the drug may be something that should be routine, and then there's a variety of other activities. This is a point, this was from a syringe program in Washington State. They had 583 new participants. 443 of them were individuals who use opioids. 140 were people who used methamphetamine. And they did a whole bunch of surveys with them. 82% of the individuals who used opioids reported they felt that they were going to need to reduce or stop their opioid use at some point, 82%. Among those who used methamphetamine, it was about half that. So the point of this is that the individuals who use methamphetamine are not chomping at the bit to get into treatment. They'll come into a syringe exchange program, but their interest in getting into abstinence-based treatment is far less. And because we don't have a buprenorphine or a methadone, the treatment is way less attractive to this group than to individuals who use opioids. What do we have for treatment? This is surprisingly quick review because it's very clear what the evidence says. There have been about 7 meta-analyses and systematic reviews done in the last 3 years on treatment for stimulant use disorder, psychosocial treatment. This one was done by a group out of Oxford, England, Oxford University. 7,000 patients, 12 different interventions, 50 clinical studies. Their conclusions were the combination of contingency management and community reinforcement approach were the most efficacious and most acceptable treatments in the short and the long term. Very definitive statement, which is rare from meta-analyses in my experience. This is from a Cochrane collaboration, looking at 27 randomized studies. The comparison between different types of behavioral interventions showed results in the favor of treatments with some form of contingency management in respect to both reducing dropouts and lowering cocaine use. The Lancet, a paper out of Australia, psychosocial interventions other than contingency management have weak and non-specific effects on stimulant problems, and there are no effective pharmacotherapies. That was published late last year, Mike Farrell and a great group from Australia. This was published here in the US, Drug and Alcohol Dependence in June. 44 studies reviewed. While contingency management interventions showed the strongest evidence, there was some evidence that CBT and CBT together with contingency management were effective. Brown and DiFolio last month published this article on contingency management treatment for meth use disorder. 27 studies, all included contingency management intervention for methamphetamine users. The outcomes on these different domains, they showed reduced methamphetamine use in 26 of 27 studies, longer retention in treatment associated with contingency management, more treatment sessions attended, higher use of other services, reductions in sexual risk behavior, increase in positive affect, and decreases in negative affect. And these folks were the groups that responded best to the treatment. The point is, out of all this stuff, contingency management unanimously gets by far the highest rates of review for effectiveness. There's some data for cognitive behavioral therapy, some data for community reinforcement approach, but both of those, the best data are if you combine them with contingency management. Motivational interviewing, the data is kind of messy, but you should just put motivational interviewing in the drinking water. It really is a necessary skill for treating anybody with SUD. And we have some data and have published a number of papers on the value of physical exercise for those with methamphetamine use disorder. Now, contingency management is a technique that involves the use of incentives. That is, people come in, give drug-free urines, or people come in and show up for treatment, and you can earn things. You can earn gift cards, you can earn vouchers, never money is never given, but something is earned for these promoting drug promotion behaviors. And I'm not going to go into the details of contingency management, but it's also called motivational incentives. It's using incentives, positive rewards, to reward patients for giving drug-free urines, showing up at treatment sessions, or other related behaviors. The studies in general have used levels of incentives of $500 over 12 weeks, something in that neighborhood, $100 to $200 a month over treatment, which may sound like a lot, but when you think about it, producing a huge reduction in stimulant use is maybe a bargain for that. However, currently in the United States, Medicaid regulations restrict the amount of incentives that can be used to $75 per patient per year. So in many ways, as I've gone around the country doing these talks, I say, yes, we have this thing that works. However, you can't really use it. And because of these Medicaid restrictions. With non-Medicaid patients, you can use whatever level you want. But right now, there's a group of us working with, well, we started working with Health and Human Services with Mr. Azar, and have now decided we have to go to the legislative route because we didn't get a very positive response. But there's a lot of efforts to try to get this level increased. California, for example, is going to put higher rate levels of incentive in their 1115 waiver that they submit to the federal government. The other issue always has been challenging is if you're going to, okay, even if you believe and you could use higher levels, where do you get the money to buy these incentives? That's a challenge, although with the current SOR grants, that money can be used for incentives. And finally, the whole idea of incentives takes some getting used to for clinical staff. And that seems to be going away in my experience, but it's the idea that people are earning stuff for doing what they should be doing anyway can be offensive to some individuals. I mentioned this exercise thing, and I won't go through. We did a study with people in long-term residential care. Half of them got a 3-time-a-week exercise program for 8 weeks. Half of them got a class. We found that the exercise group had obviously improved physical conditioning. Their oxygen turnover and a bunch of other measures were improved. They didn't gain as much weight, which they often do in the early weeks of treatment for stimulant use. We got increased heart rate variability, better cardiovascular functioning. We got reduced symptoms of anxiety and depression, reduced craving for meth, reduced improved recovery of the dopamine system. We did PET scans on them pre and post, and reduced relapse when they went out into the community. There was a much lower relapse rate to methamphetamine. I think exercise will become a standard part of treatment in the future as we get more data on this. But right now it's still being, still a fairly new idea. You heard Tom Costin last year, who is in the middle of doing all these studies. Right now, this is my best reading and my colleagues who I work with, best reading of where we are with methamphetamine use disorder medications. Bupropion or Wellbutrin, mirtazapine, Remeron, both have randomized clinical trials supporting their usefulness. Mirtazapine just had a second trial in San Francisco, a second randomized clinical trial showing significant effects. Those are the two leading candidates, but I do have to say the clinicians I've talked to who have used these medicines with individuals who use methamphetamine do not describe a response like giving buprenorphine to an individual who uses opioids. It's not like the patient goes, oh, I feel so much better. They get a little less craving, they get a little less depression, they get a little more functioning, but it's a relatively subtle benefit. But that's where we are right now, medication-wise. Last thing I'll talk about is, because I've gone around now for about 3 years talking about this treatment stuff, and states and counties have said, well, what should we be doing? And I say contingency management. However, you can't really do contingency management. They say, well, what should we do then? I finally, people in West Virginia sort of harassed me into putting together my best guess as to how to combine whatever evidence-based treatments we have and try to get them implemented. So we put together a manual that we call Trust Treatment for Individuals Who Use Stimulants. And it combines MI, CBT, CRA, MI meaning motivational incentives, or the $75 incentive that you can use, and the rest, and physical exercise. We put it into a manual, and we're now training in 6 states on the use of this to see if it works. All of the elements have evidence. The manual itself obviously doesn't. We're just starting it. The focus is to have a protocol that produces a positive, compassionate, respectful, non-judgmental relationship with people, with the focus being, if we can get them into treatment and keep them in treatment, regardless of how they're doing in treatment, they'll die at a lower rate than if they're out of treatment. And that we really want to focus on retention in treatment and reduced drug use. So I won't go through the whole training, but this is my email if you have questions. If we're sending out that manual at no cost to people, by the way, if people are interested, be happy to send it out, and you can look at it, use it or not use it, but it may have some ideas for your treatment of the population. And I will stop there.
Thank you, Dr. Austin. That was awesome. We do have time for one question. Can you see it in the chat, or should I read it?
Would you read it, please?
We have one question from Dr. Roy Stein. A few years ago, VAJ implemented contingency management in its SUD IOPs around the country, led by Dom DeFilippis at the Philadelphia VA. Has outcome data been reported for this large initiative?
I talk with Dom about once a month. The VA really, and I'm glad, thank you very much for that comment and question. The VA really has gone full-time using contingency management as its main treatment for treating individuals with stimulant use disorder. It's now the treatment in about over 100 VA hospitals for people with cocaine and methamphetamine use disorder. I talked with Dom there. They have data. They're very positive about the response, how it's retaining people. I've talked to other doctors, but I haven't seen a systematic data set yet on the use of it. So the answer that I have is, I don't think there's any data yet, but sure it will be coming in the near future. And the qualitative information is very positive about the use of contingency management.
Wonderful. Thank you again, Dr. Austin. It was a great talk.